Welcome, folks. We're going to give it a minute here to let some folks join. Um, Good morning, good afternoon, wherever you might be joining us from. So happy to have you all here. Um, as we are waiting for folks to join, you are more than welcome to rename your self, or if you would prefer to put your pronouns along with your name, that would be wonderful. We also have a chat available to you if you want to say hi or let us know where you're joining us from. That would be lovely as we wait for folks to join. And for those who are on, this is the webinar supporting and understanding tobacco cessation programs in public housing, primary care. This is a two-part webinar series. If you are in the right place, if that sounds familiar to you. Welcome, welcome, everybody. Thank you. Wonderful. Right. Well, we have a full agenda for you today. So as folks continue to come in, I will go ahead and get us started so we stay on time and respect everybody's time and make sure we have enough time at the end of the session to have some Q&A. Um, so welcome again. We'll go through, Fide, can you go to the next slide for me, please? Just an overview of the agenda, what we hope to accomplish today. We'll go through some introductions where I'll introduce myself, my partnering organization, as well as our subject matter expert. And then we'll have some, so after the introductions, we'll do some data from or hearing from you, kind of wanting to get a gauge of what you're experiencing, some questions that will help us kind of hone and refine as we're going through this presentation, as well as the webinar we'll be having next week. So really hoping that you all will engage with us and really make sure that we're targeting the information that you want to hear. Then we'll have some data from the field, kind of giving an idea of the landscape from those who are residents of public housing or those who are experiencing homelessness to set the stage. And then we'll hand it off to our amazing guest speaker from the American Lung Association, Ann DiGiulio. And then, like I said, at the end, we'll have some time for some Q&A. So really looking forward to you all engaging with us. You can do that through the chat. We really want to make this engaging so that we're just not talking at you for a full hour. Okay, next slide. All right, we'll start with introductions. My name is Elena Boyer. I am Senior Director of Programs at the National Healthcare for the Homeless program, National Healthcare for the Homeless Council. And we are a national organization that provides training and technical assistance. And our mission is grounded in human rights and social justice. The National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. At the bottom of the slide, you will see our disclaimer. This is a webinar hosted by our organizations and funding mainly through HRSA, the Health Resources and Services Administration. I will hand it over to my colleagues and partnering organization. Next slide, Fide, and I'll let you take it from here.
Thank you, Elena. And it is a pleasure to meet you all and be with you in this presentation today. So here, this is just also our disclaimer for the National Center for Health and Public Housing. This information or content is 100% financed by the Health Resources and Services Administration. And the mission of NCHPH is to strengthen the capacity of FQHCs that are PHPC health centers and by providing a range of training and technical assistance. And then here is just an overview of the NCHPH team. My name is Filipina Sandoval. And with us, we also have Dr. Jose Leon, who is the Chief Medical Officer. We also have the Manager of Policy Research and Health Promotion, Dr. Kevin Lombardi, and Bob Burns, who might be joining later on, and then Chantel Moore, who is not in with us today, but she is always in charge of the communications and all of that information. All right, without further
Wonderful.
ado.
Wonderful. Thank you, Fide. And so I just want to take a moment, and we'll hear from her a little bit later in the slides, but I wanted to acknowledge our great subject matter expert, Anne DiGiulio. And Anne joins us. She is the Senior Director of Nationwide Tobacco Cessation and Health Policy at the American Lung Association. Anne oversees the Lung Association's Tobacco Cessation Policy Project, having authored numerous MMWR articles and created resources and policy briefs on key tobacco cessation issues. She is also the Lung Association's expert on tobacco cessation policy and healthcare issues, including Medicaid expansion, and marketplace healthcare. Originally, Anne is from Chicago, Illinois. She received her BA in political science from George Washington University. She currently lives in Washington, D.C., enjoys running, cooking, and cheering on the Washington Nationals. Welcome, Anne. We're so excited to have you with us, and we're very lucky. So thank you. So with that, I would love to hear from folks who have joined us today. And so we're going to go to a little bit of a Mentimeter and engagement opportunity. Again, this is how we can make sure that we're responding to your needs, and we are hitting those topics that are most important to you. Oh, I'm so sorry. I take that back. One slide. I do want to mention that what's coming ahead. I mentioned that this is a two-part series. This is webinar one in that series, where we're going to do some of that level setting and understanding the tobacco environment with the agenda that I laid out a few slides before. And then next week, we really hope you all come back and join us again, where we're going to apply some of that information and implementing these strategies in clinical practice using case studies led by Dr. Lombardi and myself. And then also, the information that we receive from you all today, we will be having a podcast that will be coming out sometime this spring in 2025. So hopefully you all will be looking forward to that. And again, we will be using what we learned from you all in that series as well. All right, sorry about that, Fide. Next slide. Okay. So if everybody would like to take a minute, use your camera on your phone to screenshot this QR code where we just have a few questions, again, that will help us make sure we're responsive to what you all are looking for. You can use the QR code, or you can go to menti.com and enter the access code on this slide, 52519257. So let's give everybody just a second here to make sure that they can join us. And while we're waiting for people to do that, if you've just joined us, please feel free to introduce yourself in the chat. We are glad that you are here. Let us know where you are from and joining us today. Thank you. And we'll switch to Mentimeter so we can see those responses in real time. Okay, wonderful. So you all should be seeing the first question, which is, does your clinic screen regularly for tobacco use? This is a yes and no answer.
So it looks like the letters may not be a little bit clear, but just to clarify, the one on the left side is the yes, and on the right is the no.
Oh, thank you, Fide. Yes.
Yes.
We'd love if we would have a few more responses. Again, if you're just joining us, you can use the menti.com link that's in the chat and at the top of the slide and enter the code, and you will be joining the Mentimeter engagement. And again, this question is, does your clinic screen you regularly for tobacco use? And you can also use the chat if you're having trouble engaging with the Mentimeter. And I recognize that some folks on this call might not be a clinic. And if you're not a clinic, that's okay. That's fine. In your day-to-day work that you do, is screening a part of the conversations that you have or discussions in your organization. Okay. I'm going to keep us moving to make sure we stay on time. Go to the next slide for me, Vide. Okay, as we look to the future of smoking cessation programs, what are you most concerned about? This is a word cloud, so you can just enter one word and we'll see it pop up here. This will be really helpful for us, again, to make sure that we are addressing the needs and understand the priorities. Hmm. Yes. Thinking about even policies that might be forthcoming could be of some concerns, chronic stress, yes. Quitting permanency. This is great. Okay, so I'm seeing stigma, chronic stress, reliability, excellent, reliability, youth access. Yes, thinking about those populations are going to be really important. Excellent. Adherence, vapes. Yes, thinking about all the ways that tobacco can be used is really helpful. Thank you. All right, let's go to the next question. Okay, we'll probably just keep this to one word so we can move forward and stay on time. But what words come to mind when you think about the implementation of tobacco cessation programs in your clinic? And again, if you're not a clinic, what are some of those challenges that you're experiencing now in terms of implementing these programs? Is it the desire to quit? Is it fitting in a workflow? Is it motivational interviewing? What comes to mind when you think about that? Continuity, provider interest, yes. Access, engagement. Okay. Well, interest in time. Please feel free to be thinking about these questions as we go through the presentation today. You can always enter those into the chat and engage with us. Oh, great. Some more coming in. Thank you. Social services, that whole person care. hmm And prioritization. It might not be a priority for some folks. Great. Wonderful. Okay. Well, thank you, Fide. I think that's the last one. Wonderful. All right. So the next thing that we're going to jump into, and again, I just want to thank you again for those responses. I do think that hopefully we'll be touching on some of those today in this presentation. And again, it gives us information and feedback on how to refine and think through our presentation next Thursday. All right, great. Next slide. So I'm just going to start with a little bit of landscaping and environment of what does tobacco look like in persons experiencing homelessness. My organization, that's our population that we primarily focus on. And it's a little bit of tricky situation. We have a lot of complex individuals, and smoking cessation might not be one of their top priorities when they're unhoused. But what we found was, in looking at the research, and I just want to draw everybody's attention to the link at the bottom, I want to thank the UCSF Smoking Cessation Leadership Center, which is a great resource for you to find all of this information. And what they found was in the research is the prevalence of tobacco use among folks experiencing homelessness usually ranges between 57 to 82% that smoke. And that rate has not changed in the past 50 years. Homelessness is a stressful environment, experience, traumatic. Experience for folks. And so sometimes tobacco use can, some folks use that for alleviating some of that stress. And so what we're seeing on the graph here is that as we're looking at that 57 to 82% range, a recent study done in California by Margot Kuchel looked at that within specifically California. And in that population, about 70% were current smokers. And when you compare that to the general population, which is around 11%, you can definitely see that there are high smoking rates in this population. Next slide. Some of the reasons that we see this is that we have a high dependence on nicotine, usually between 13 cigarettes packs a day to or 10 to 13 cigarettes a day. Um, they usually start early in the morning if they're smoking, so within 30 minutes of waking. We also know that 60% who reported smoking use other forms, so that can be chew, it can be smokeless types of tobacco products, e-cigarettes, and those types of things. And I think the next slide will give a little bit of the reasons why. Next slide. So the reasons that we see this is, as you can imagine, when we're looking at a lot of the social drivers of health, we see that there are structural inequities. There are the social drivers of health inequities. There are commercial determinants. So tobacco industries marketing particularly to these vulnerable populations. Looking at the social norms, a lot of times, especially with our populations that are outside, it can be a communal type activity in which they might partake in. We also know that we have high rates of PTSD as well as other mental health issues that are going on. And so smoking can be a coping mechanism. In the work that I do, we also know that it can be used as a tool for de-escalation when folks are in a crisis. Or there are oftentimes in shelters where there might be disagreements and we need to de-escalate. And so I've heard that also smoking can be a tool for coping with that. We also know that it's co-occurring with a lot of other types of substance use. We see a lot of opioid use, and so a lot of times they go together. So these are some of the reasons that we see high smoking rates in this population. Next slide. And some of the barriers to quitting is that there's high levels of relapse in our population. And so it makes success to quitting very difficult. A lot of times in homelessness, we see cycling in and out of homelessness, added trauma on top of trauma. We might have abuse situations that are going on. So it makes it really hard to have that continuity, as we heard in the Mentimeter to occur. We also know that there are sustained access of effective interventions that have addressed high levels of nicotine dependence that co-occur with psychiatric and substance use disorders. As I mentioned, there are a lot of social triggers that folks experiencing homelessness might be experiencing and might depend on that nicotine to occur or access to nicotine. We mentioned already the social norms that are pervasive within homeless settings, and as well as it can be used as a bridge to therapeutic alliance between, like I said, providers and clients. And lastly, just mentioning that while we know that mental health and substance use could pose barriers to quitting, treating tobacco use does not pose barriers to substance use recovery for other items or other uses, and may improve mental health outcomes as well. So while tobacco cessation might not be one of the first things that some of our providers that take care of persons experiencing homelessness go for, we do know that when worked together, we could also be treating mental health as well. Next slide. And I think it's on to you, Dr. Lombard. Oh, no. I will just quickly touch on this a little bit. We do in the health center environment collect there's a data set that we collect yearly from our health centers that show two tobacco-related variables: tobacco use disorder among patients that are seen within health centers, as well as smoke and tobacco cessation counseling. And so we look at that in three different levels. We look at it at all health centers. There are 1,300, excuse me, over close to 1,400 health centers. We take that data and we look at healthcare for the homeless health centers specifically that receive specific funding to care for those populations. And then we also look at clinics that are not tied to larger health systems that are solely receiving healthcare for the homeless funds. And in doing so, we can look at number of visits, we can look at number of patients they see, and the number of visits per patient. And so what you're seeing here is that individual or clinics that see predominantly persons experiencing homelessness at the bottom, they do have higher rates of visits per patient. Um, and then we're also seeing that the delivery of tobacco cessation programs and counseling really seems to be the same across all levels of the health center uh, environment, between health centers as well as those that are particularly serving folks that experience homelessness. So this is just a little bit of a background and landscape of what that looks like in this population. And now I will hand it over to Dr. Lombardi.
Hey guys, let's take a step into the clinic now. Next step. Let me draw a picture for you. You sit down at 8 o'clock a.m., you put your computer open. You've got a list of 7 appointments that you need to get done for 12 o'clock. Each of those you have about 15 minutes for, and you've got to write a note for each of them. Because they're back to back, you're probably not going to be able to get those notes into lunch while you're eating your lunch. There's a necessary component for your billable clinic visits, and that's that you need to mention tobacco cessation. It's a little checkbox that is always there on every medical record every time a doctor sees a patient. Now, the difficulty is how often that question is actually asked, who it's asked by, and how long those conversations are varies significantly from provider to provider. And in many places, the checkbox has become what it really is, just a checked box. It often is not a conversation. So let's take a look at our residents of public housing, how they're experiencing smoking, and seeing how we can plug that into our context and find those opportunities for discussing this with patients. Next slide, please. This is an analysis I did based on HRSA data, comparing it to CDC data. So let's take a look at the nation here, gauging smoking cessation. You'll be getting these slides, and there are links here, by the way. They'll always be in the bottom left. Of smokers in the United States, within the last 12 months, 67.7% have said they have a desire to quit. 53.3% have said they attempted to quit, but only 8.8% successfully quit. One, what should these numbers say to you? One, it talks about how severe the chemical dependency on nicotine is. That's a very small number of people who are successful compared to those who have actually started. Two, it speaks to the need for supportive patients that go through this because it's a difficult process. Most folks that have gone through this have tried more than one time, and trust and believe they remember and know how it feels like to be that 53% and not be that 8%. It's often a difficult and discouraging process. That's why our patients need social support when they're going through it. Let's next slide, please. So here's some data. I won't put you through this, but I'm going to take pieces of it. What I did here is looking at HRSA's data sets, looked at our residents of public housing and compared them to folks that weren't in public housing. That allowed me to look specifically at the needs of this patient population in terms of their quitting and their smoking behavior. Next slide. And here are our reference and comparison groups here. We've got folks that are in all other housing, those that are HUD assisted, and public, those are in public housing. So let's see what the differences are. Next slide. And next one too. Okay, so when we look at patients reporting tobacco use in the past 30 days, and this is data across all FQHCs, okay? The US average, by comparison, is 10.9%. But when we look at our health center patients, they have a rate that's almost 3 times as much as the general U.S. populations. When we look at our HUD assisted and our public housing patients at FQHCs, they have even higher rates of smoking. That tells me in particular that this is a population that smoking cessation needs to be a focus, that checkbox needs to be a conversation every single time. And these are folks that, if they also say concurrently are scoring high on an STOH questionnaire, get them with social services. Stopping their smoking is one of the best things you can do for their quality of life. And let's look at patients who have smoked at least 100 cigarettes in their lifetime. This is roughly the definition of a smoker. And you can see again that our HUD-assisted and public housing patients are 3 or 4 times as likely to fall into that category. That's a big difference. Next slide, please. So let's look at the good stuff here. Intent to smoking. People don't just stop smoking. There is a long, complicated, and often drawn out process neurologically that patients go through. It's a coping process. It's deciding to want to quit. It's finding the motivation, all of which does better under social support. But when we look at intent, patients who have expressed an intent to quit for good, the US average, 67.7% of smokers want to quit. But when we look at our HUD-assisted and public housing patients, we find that that's actually even longer, even higher. Public individuals living in public housing who are smokers are over 10% more likely to want to quit than the general population. What this is telling me is this is a population that wants the product. They want to be sold the product of quitting smoking, and health centers fulfill the role of providing that product. And here's another one: patients who smoke cigarettes every day. This speaks to the severity and the frequency and volume of smoking in public housing. We can see that compared to the US average, 12.0% of individuals in the country, 56.8% of residents of public housing are smoking every day. What does that tell you? Smoking and nicotine is everywhere in that environment, and that provides an additional barrier to quitting because it's just there. Next slide, please. And that's all I have for you folks. Thank you so much for your time, and thank you for your service to your communities.
Well, thank you very much, Dr. Lombardi. That was really very helpful. And apologies, I'm getting over a bit of a cold, so if I sound kind of weird, that is why. As Elena was very generous to introduce me, my name's Anne DiGiulio. I'm the Senior Director of Nationwide Tobacco Cessation and Health Policy at the American Lung Association. As my title suggests, and as Elena mentioned earlier, I work on our tobacco control policy and our access to care portfolios. So I'm going to go over today kind of 3 main topics, hopefully fast, so we've got a lot of time for discussion. So I'm going to talk kind of about the landscape of tobacco control, some of the policies and kind of how we got here and some things we're seeing now. I'm going to go into some of the specifics around tobacco cessation. So I will try not to repeat what Dr. Lombardi said, but hopefully be able to add to that, including kind of what types of patients get what types of coverage, because it really depends. And then I'm going to zoom out a little bit and talk about the broader access to care sphere and some challenges that we're anticipating coming and unfortunately have already seen some evidence of. So if you can go to the next slide, I can just jump right in. Great. So I'm going to start with tobacco control policy, kind of where we are now and how we got here. So if we can go to the next slide, one of the landmark pieces of legislation in tobacco control, at least at the national level, and we'll keep it to the national level because states can do a lot of things, is the Tobacco Control Act, or the Family Smoking Prevention and Tobacco Control Act. I always refer to it as the Tobacco Control Act and will do in the rest of my slides, so apologies if that is confusing. This bill was passed and signed in 2009, so it's still relatively new. It gave the Food and Drug Administration, or FDA, I'll be referring to that as FDA throughout, authority over tobacco products. Specifically, it gave FDA authority to regulate cigarettes. And then in 2016, the FDA issued what we call the deeming rule, where the FDA deemed or named other types of tobacco products, including e-cigarettes, as products they can regulate. So that was a huge step forward. And anybody working in tobacco control at that moment in time remembers that. The other thing that the Tobacco Control Act does is it gave FDA the authority to issue product standards. So this can be around kind of how products get made. A couple of these are, and I will promise I will go into some more detail in a few minutes on these, are prohibiting flavors of tobacco, so flavoring characteristics, or limiting the amount of nicotine in tobacco products. So if we can go on to the next slide. I'm going to dig in a little bit to the deeming rule. So the deeming rule, as I mentioned, came out in 2016. So now there are all these new products that are under FDA regulation. A lot of them, including e-cigarettes, had been on the marketplace for years. So they had to go through applications, and then any new product has to go through what we call a pre-market tobacco product application, or PMTA for short. So the product manufacturer, so the tobacco company, has to demonstrate that this product is appropriate for the protection of public health. So that is an important standard to look at. FDA has to take into consideration, and the product manufacturer has to prove that this is not going to appeal to non-users. So this will not have an appeal to kids, and that current users are adults, or switching to this product completely could potentially lead to some positive outcomes. The Lung Association has a lot of thoughts on that, and I can get into that later. Any product that goes through the PMTA product successfully receives a marketing order. This does not necessarily mean that this is a safe product to use. It just is allowed to be marketed to the public. So just as that, there's generally some confusion on that, but I just wanted to flag that. And then in March of 2022, as we know, the tobacco industry loves loopholes. And pre-2022, they had decided that if you create synthetic nicotine in a lab, that doesn't count. And so in March of 2022, that synthetic nicotine loophole was closed. So synthetic products with synthetic nicotine do need to go through the PMTA process before being sold to the public. And again, if they don't have a marketing order and are gone through the PMTA process, they're currently being sold illegally. So we can go to the next slide. So product standards, this is kind of the other piece, or one of the other pieces that the Tobacco Control Act does. And so what is a product standard? So a product standard is a rule from the Food and Drug Administration, or FDA, about how a tobacco product can be made. These product standards, or these rules, have to go through the traditional notice and comment period. Typically, we look at a notice and comment period. So the agency proposes a rule. In this case, it would be the Food and Drug Administration. The public, any of us, would have the opportunity to comment for, usually the shortest comment period is 60 days. I've seen them as short as 30, but they can always be extended. So there's, and then after that, the Food and Drug Administration has to go through and read all those comments and have a response to all those comments, and then issue a final rule. So it's a pretty drawn out process. So some examples of product standards could be, and neither of these have been finalized. So one is, prohibiting the sale of menthol cigarettes and flavored cigars. So that was something that was proposed well over a year ago. That rule was never finalized, and it was withdrawn by the Biden administration. So that will not be finalized anytime soon. And then just yesterday, the Biden administration proposed a new rule that would limit the amount of nicotine in a tobacco product. This includes cigarettes and some other combustible products. It's not comprehensive for all products. But again, the final rule hasn't been issued, so the standard doesn't exist yet. It's just an idea that's out there. I don't know the comment period length for this. What we were told is it was going to be very lengthy, so well in excess of those 60 days. But if you're interested in commenting on this, or if you have thoughts on this, anyone as a private citizen can write in comment saying that the FDA should quickly finalize this. So if you belong to part of an organization, your organization may have a process. I know the Lung Association does. You shouldn't write comments on behalf of your organization without getting approval, but anyone as a private citizen can write comments. And I'm happy to talk more about that later. So we can go to the next slide. A couple of trends we've seen recently is really just a ton of industry aggression from the tobacco companies. We've seen, and I think a lot of people are aware of this, the huge lobbying and campaigning effort to kill the menthol cigarette and flavored cigar rule that I mentioned before, the selling of products that don't have a marketing order from the FDA, that PMTA process I talked about a moment ago. Just today in JAMA, there is an editorial by some CDC authors around Geek Bar and Raz, which were new to me, which are e-cigarettes that incorporate smartphone technology that are very discreet to use and appeal to kids, and are all being sold illegally with really high use rates. So, and again, additionally, there's new products every day that look like toys, so it's harder for educators and parents to understand when somebody is using an e-cigarette versus when they're using their phone, which is great. And then we're seeing new manufacturing companies or new manufacturing plants pop up, and tobacco companies really embedding themselves in the economy of states, which is kind of horrific, including some manufacturing companies for products that, at least when they were built or signed, did not have a marketing order, so for illegal products. So that's been really great too. If we can go to the next slide. So now I'm going to kind of go through tobacco use rates. Again, what does this mean for people? Because, all these things in the world can be good or bad, but we need to see what it actually does for people. So if we go to the next slide, who is using tobacco products? And Dr. Lombardi kind of went through this, so I'll try to be quick about this. And I pulled these from the most recent MMWR on tobacco use data, so it's CDC data. But nationally, 11.5% of adults smoke or use tobacco or smoke, excuse me. But there are disparities that exist. That 11% is not across the board. A couple of ways we see it is income level, and the first and third bullet will tell you that. So individuals with private insurance smoke at a rate of 8.6%, while Medicaid enrollees, it's 21.5%. And uninsured individuals, it's 20%. So just huge disparities there. That third bullet actually talks about specific income level. Again, you can see the disparity there as well. Another place we see this is behavioral health. The way that they break down the data in behavioral health changes very frequently. So this past MMWR on smoking rates looked at serious psychological distress. People that are in serious psychological distress have a much higher smoking rate than those who don't. So again, smoking is not necessarily an activity that happens evenly across the board, and major disparities exist. So again, that's important. If we go to the next slide, which actually has some better news, and this is the 2022 data on attitudes towards smoking. Again, Dr. Lombardi went through them. Again, I think, again, most people want to quit, and that's so great, but it is not, and it is actually fairly even across the board, that people want to smoke, that people that smoke want to quit. So even though there are disparities when it comes to income level or when it comes to insurance type, everybody wants to quit. So how can we help them do that? If we can go to the next slide. I'm going to now talk about tobacco cessation and the current landscape on tobacco cessation. And I apologize. It looks like this slide got a little bit cut off, but that's okay, because I will talk about it. So treating tobacco use and dependence is the most recent guideline on kind of what the best practices and the guidelines-based practices of helping people quit are and what that treatment is. This has been reaffirmed by the United States Preventative Services Task Force. So that's what we have. I know it's old. Unfortunately, there has not been a new medication since 2008. So if you're a drug developer, this is a cool opportunity. If you're not, this is where we're at. So there are 7 FDA-approved medications. NRT is nicotine replacement therapy. We've got the gum, patch, and lozenge. Those are all over-the-counter medications. For most health plans, if you have a prescription, there's going to be no cost sharing. So that's just something to keep in mind as you're talking to patients. There's also the inhaler and nasal spray. As most of us probably know, The inhaler is currently not being manufactured right now, but fingers crossed, maybe sometime in the future it will be again. But those are both, you need a prescription for both of those. Bupropion, which is also sold as Zyban as a brand name, is also it's a pill that one takes. And then varenicline, which is Chantix. Chantix is also not being manufactured, but there is a generic varenicline that's being manufactured. So that is, again, a pill that one takes, and you need a prescription for it. And then there are 3 types of counseling. There's individual counseling, so that's one-on-one, just sitting, talking to somebody. Group counseling, so that's a conversation that you might have in a group or a class. And then there is phone counseling. So this can either be through the quit line or phone counseling in a different way. Some really interesting thoughts when we get into telehealth about like, what is a phone call? But we're not going to go into that now. So those are kind of some of the things, the types of counseling. We go to the next slide. I'm going to talk about some barriers. And I think when I want to talk about barriers, I think it's really important to think about these barriers through the lens of somebody that is low income or maybe experiencing homelessness. And while these barriers might not be that onerous to somebody like me, who is sitting very comfortably in my apartment with access to the internet, with a very flexible job that can make phone calls during work and do that, as opposed to somebody who has an hourly job that doesn't have that ability, who does a service job, or again, doesn't have access to reliable access to some of these things. So what we're looking at is cost sharing. Again, low income, even a little bit of cost sharing we know can be a deterrent to get care. And so this can be either co-insurance, co-pays, or part of the deductible. Again, if you have to go to counseling once a week, that could be paying that copay once a week, which adds up very quickly over time. Prior authorization. So this is asking the insurance company to okay what the doctor and the patient have already agreed on is the best course of action. Again, these medications have all been on the market since 2008. None of them are new, and they're all considered first-line treatments, and that's another important thing. All 7 medications are considered first-line treatments. Duration limit, you can only be on it for so long. Yearly or lifetime limits, you can only try to quit maybe once or twice a year, or you can only try to quit once or twice per lifetime on a certain type of insurance. And we know that on average, it takes about 8 chances for somebody to quit. And so that can be really bad. Dollar limits, the insurance company will spend $500 for your quit attempt, and after that, it's on you. Stepped care therapy, you have to try and fail at one medication before you can get to a new one. And so again, we don't want to encourage anyone to fail, and maybe they've already tried the NRT gum on their own, and so now they're trying to get bupropion or varenicline, and they're not being able to do it. And then required counseling. And anyone who works with patients is probably scratching their head and saying, Anne, you seem kind of smart, but this is dumb. Because we know that the best chance for somebody to quit is using both counseling and medication in combination. That being said, we don't want there to be a barrier for somebody to quit by having to go to counseling. Maybe somebody has limited minutes on their phone. Maybe they don't have access to childcare to go to an appointment. Again, maybe they can't pay that copay every week to get to that counseling class. So there's a lot of reasons why required counseling can actually deter somebody from making a quit attempt. Again, especially when you look at it through the lens of somebody who might not be as affluent. And if we go to the next slide. So just real quickly, to make sure we're all on the same page, when we talk about a cessation intervention, there are kind of 3 aspects of that. First, that's screening for tobacco use. And we had that question at the beginning, and Dr. Lombardi kind of talked about it, that sometimes it just goes into a hole. There's really going to be no reimbursement or coverage of that you're just supposed to do it. You can talk about, like, at least in the earlier iterations of meaningful use, there was, requirements to screen, but that doesn't exist for most people anymore. Counseling, again, those can be reimbursable codes, and medication is usually reimbursable. If we go to the next slide, I will say that the type of insurance coverage you have is going to depend on the type of benefit you get for cessation. So if you've got Medicaid expansion versus standard Medicaid, there's a different floor, there's a different requirement. Medicare has another requirement. Private insurance does what Medicaid expansion does. I'm not going to go into TRICARE or the Veterans Administration. That's for active military and then for veterans. But those have other requirements as well and other decision makers. Additionally, some types of private insurance and specifically Medicaid, your coverage can depend on which state you live in. So all to say is what I'm going to go into is very, very confusing. I will try to go both quickly so I can get to the end and we have time for questions and make sure I get it all in. But if you've got questions, I will make sure to put my email in the chat at the end so we can, talk specifically after that. So if we can go to the next slide, I'm going to start with standard Medicaid. So these are the people that are kind of the lowest income people who would have qualified for Medicaid if their state didn't expand. If you're in one of the 10 states that's a non-expansion state, your entire Medicaid program, standard Medicaid. And so prior to the Affordable Care Act, tobacco cessation medications were kind of considered in like the cosmetic type of medications and did not have to be covered by state Medicaid programs. Section 2502 of the Affordable Care Act changed that and required these medications to be covered. It does not address counseling. There are still states that aren't covering all 7 medications, and states are still allowed to charge a copay. Again, these are for the lowest income people where copays are allowed to be charged, which is kind of horrific. If we can go to the next slide. For standard Medicaid for pregnant people, there's a different requirement. And I apologize that I've got pregnant women and pregnant people. The statute says women, the Lung Association's language says people, so please just bear with me. So it's a 2010, this coverage requirement went into effect in 2010. Essentially, all pregnant people on Medicaid or pregnant women on Medicaid are supposed to have access to all 7 medications and all 3 forms of counseling without cost sharing. And so this is written into the law. It's a very, very strong section of the law. It's really great. So 4107, if you're really a legal policy geek like me, you can look it up. It's a really, really great language. I love it. But we can move on because not everyone is as lucky as to have the requirement that the pregnant people on Medicaid do. Next slide. Great. So for most private insurance, the Affordable Care Act did a number of things. Well, and the few that I'm going to talk about. So it said that you have to issue insurance to anyone who applies in the open enrollment period. That's guaranteed issue. So you can't say you've got a pre-existing condition, no. It allows children to be on their parents' insurance up through age 26. It limits what you can charge a patient. So you can only charge the oldest person 3 times as much as the youngest person. You can vary the rate for insurance based on their family size. So if they've got more people, you can charge them more money. Geography, so you can, the cost of healthcare in New York City is probably more expensive than the cost of healthcare in rural Kansas, just because property cost is more. I could be totally wrong on that. I'm just making that up, but you can do that. If real estate's more than one, you can charge different by geography. Unfortunately, you can also charge more if somebody uses tobacco than if they don't. So, and the Lung Association does not support the tobacco surcharge, which this is, and I can get into that later. The other thing that private insurance is supposed to do is it's got to cover what we call the essential health benefits. And I'm going to get into that on the next slide. But this is kind of what we think of what healthcare is. So this is prescription drugs, hospitalization, all that. So they have to cover what healthcare is. They can't just say, and this one doesn't cover hospitalizations. And then we know that states can add additional protections. They can either prohibit or limit the tobacco surcharge and do other things. We go to the next slide. So these are those essential health benefits. And then I'm going to quickly ask to go to the next slide. I'd like to draw everybody's attention to these preventive and wellness services as the second one from the bottom. And this one is really important for us because if we go to the next slide, the way that the departments have defined this is that anything given an A or a B grade by the United States Preventative Services Task Force has to be covered without cost sharing. And these are clinical guidelines. So somebody like Dr. Lombardi would definitely understand, okay, this is a clinical guideline. This is how I treat my patient. That being said, it's not insurance language. So back in 2014, there was something called an FAQ, which is sub-regulatory guidance, which you don't need to know about. But the important part is this FAQ translated those clinical guidelines into insurance language. And so what they said was that tobacco cessation has to be covered. You need to do all medications, at least 4 sessions of counseling, and you have to do at least 2 quit attempts per year with no cost sharing or no prior authorization. So if we go to the next slide, we'll see that this requirement, oh, I'm sorry, this slide also got cut up, is in almost all private plans, including plans sold on the exchange, small group plans, individual plans, Medicaid expansion plans, not standard plans, and then some association health plans. Other plans have no or different requirements. So those would be those standard Medicaid plans, Medicare. Okay, it just got dropped in the chat. So these other ones have no or different requirements. And the last, from grandfather plans down, none of them have no requirements. So nope, we can go back to billing and reimbursement. So none of this means anything if the providers can't get paid, because then, something doesn't get paid, they're not going to do it. If we can go to the next slide. Billing issues, and again, I'll go fast through these, is really kind of when patients are utilizing treatment and the provider isn't getting paid. And so there's a lot of reasons why that happens, and that's what a billing issue is. So if we scroll to the next slide, there's 2 different kind of main types of reimbursement models. Again, apologies, I did not look through these slides before. I'm sorry, I apologize. So there's the fee for service. So that's when everything that a provider does gets reimbursed, specific code, and then they get a specific amount of money. Bundled payments are a little bit different. Those are for more episodic care. So a typical example of a bundled payment would be for labor, for a pregnant patient. So like their whole labor and delivery and all their prenatal care is kind of one global payment at the end. And then if a patient is more complex, the provider gets a little bit more money. If the patient, or less money because they cover everything. If it's a simpler patient, they still get the same amount of money. Fee for service is always going to exist in some way, form or another. But again, the theory is to try to move more towards bundled payments. I don't really know how much that is happening, but moving to the next slide. So just some general considerations for Medicaid. Again, the state is the decision maker. Are they a Medicaid expansion state or not? Are they fee for service? And so like sometimes an expansion state will have the same coverage for both expansion and standard. So the coverage is better. Sometimes not. We know that state Medicaid programs have to report on tobacco cessation quality measures. So that's really great. So, those are some just general considerations, but if you do want additional coverage, the state government is the decision maker. Moving to the next slide. Private insurance is significantly more complicated. Some plans, fully insured, are regulated at the state level. Again, the state insurance commissioner would be the decision maker. Self-insured plans are regulated at the federal level, so that's ERISA. Again, additional state laws and policies can go on. And if we can go to the next slide. Next slide. Okay, Medicare. Medicare is a national coverage model. Again, only NRT or only prescription medications are covered. So the NRT nasal spray, inhaler, bupropion, and varenicline, as well as group and individual counseling. But that's a national coverage decision. And then next slide. Okay, so this is the last part of my presentation, and I will, sorry, I'm going fast, but I've got a lot of information to cover. Again, if the healthcare programs aren't there, it doesn't matter what the coverage is. So that's where we're at. So if we can go to the next slide. There's a couple of challenges I want to flag for everybody. So a couple minutes ago, I was talking about one of the really great things around the essential health benefits, which is the preventive services requirement. There is a current challenge to the preventive services requirement. The lawsuit is called Braidwood v. Becerra. The name of that lawsuit will change next week because it's Becerra based on who the current HHS secretary is. But it says it challenges the required coverage of preventive services. And currently there's a ruling that USPSTF our recommendations do not have to be covered. It violates the appointments clause of the Constitution. Whole webinar, if you're interested, that we can send to you for that. Currently, the decision is only for the plaintiffs of this case and their employees, but the Supreme Court has agreed to hear the case, and we'll hear it at some point this term. So we're not necessarily worried about preventive services or tobacco cessation never being covered again. What we are concerned about is cost sharing being added to preventive services such as tobacco cessation, or maybe, they're not going to cover all 7 medications. Maybe they're only going to cover 3 or 4. So next slide. So kind of talking a little bit about Medicaid, because I know that a lot of the population that everybody works with is Medicaid. It's jointly funded by the federal and state government, and it's very flexible. So states can make a lot of decisions for their state Medicaid program. States can make changes via a state plan amendment. Those are usually not controversial, or an 1115 waiver. And those are a little bit more experimental and can definitely be a little bit more controversial. And then again, there are 40 states in DC with Medicaid expansion, meaning 10 states don't have it. So that is a huge gap in Medicaid. So moving on to the next slide, we are currently seeing threats to the state Medicaid program. We've already seen this come out of the Hill. There are threats, just sheer threats to funding, so to block grants. So currently states get kind of an open-ended amount, however much they spend, the state gets a portion of those dollars. We've seen work reporting requirements when other states have put these, went into effect in Arkansas for 2 months and 17,000 people lost coverage. We are seeing this kind of across the board. Closed formularies, so only some medications will be covered. So those are just some challenges. Again, I can talk about them more. And I've got one last slide, and I promise I'll go real quick. Kind of when we look at this through a lens of people experiencing homelessness, and this is in my last slide, we think about things like work reporting requirements. Oh, maybe the last slide didn't come. Work reporting requirements can be a real challenge if somebody doesn't have the ability to get mail in a consistent manner. Or if you don't have access to the internet, how do you report some of these things? So thinking through some of these threats in those ways. And again, apologies, I went a couple minutes over, but I will turn it back to Elena.
No, you did great. And I think the information has been really useful. I hate that you had to rush through that and know that you're not feeling well. I do know we're short on time. I really want to thank Anne. All of us will be here on next Thursday. So please bring questions with you if we didn't have time for Q&A. I did thank you, Bob, for the question that you put in the chat. I was able to respond with a quick link, so please access that link. It is again to the resource that I shared in my slides, but at the UCSF Smoking Cessation Leadership and Center has some really great promising practices and links and fact sheets. And if you have a quick link that you want to pop in there with similar resources or anything that you feel would be great, we can pop that in the link. And no fear, folks, we will be sending these slides along with resources. You will see us again next Thursday. So if we couldn't answer your questions today, we will be here for you to answer those. So with that, and I do think, oh, Dr. Lombardi, there is a question for you in the chat too, if you wanted to use the chat to respond to that, or you're welcome to come off mute too if you have a quick response.
Yeah, I'm reading. Provide data in the UDS on the number of patients treated with both medication and combination. Do you know when that will be collected and will be available? I might be wrong about this, but this might be part of the UDS Plus initiative, which is piloting right now. And my understanding is that next calendar year, the data will reflect that. That's my current understanding. Might not be exactly, but that's what I think we're going to see. As well as a number of other changes and improvements to that data quality, by the way. You will find it more usable.
Thank you, Dr. Lombardi. And I did, for those who might not be familiar with the acronym, UDS is the Uniform Data System that health centers are required to put information into. Please come back to us next Thursday, and we look forward to where we can apply some of this information, have some back and forth and peer learning. Dr. Lombardi is going to facilitate us through a great case study that I'm really excited to do. And then there's an evaluation that we would love for you all to take at the end of this. And with that, we would like to thank you, and I want to thank all of our guests, and as well as my partnering organization. So have a great afternoon, folks. Thank you for joining us, and we'll see you again next Thursday. Bye.